So I'm not a thoracic surgeon, I'm not a medical oncologist, so I shouldn't and can't tell you about the intricacies of thoracic surgical decision-making and approaches or delivering systemic therapy. But hopefully what we can give is a physician's view of what's happened since the publication of neoadjuvant treatment and how we've tried to approach that as a region in delivering a service and a real-world view of that. Translating the evidence into real-world practice, what are all the questions that are still unanswered about this, and how do you approach that with a patient in front of you? So I know you will have seen all this before. It's good to just revisit and reframe as we begin this conversation. So the CheckMate 816 trial was a trial of neoadjuvant chemotherapy and immunotherapy versus neoadjuvant chemotherapy prior to surgery. So that control arm of neoadjuvant chemotherapy was not the standard practice that we're used to in adjuvant therapies. And that showed a significant difference in event-free survival in favor of chemotherapy and immunotherapy, so a median of 32 months versus 21 months, a hazard ratio of 0.6. This slide gets showed everywhere. It created a lot of excitement that in nearly a quarter of patients that had chemotherapy and immunotherapy, there was a complete pathological response, so no tumor visible in the resection sample. It's really not at levels not been seen before in other neoadjuvant strategies. And in terms of surgical outcomes, more patients in the chemotherapy and immunotherapy arm reached definitive surgery. So 17% did not reach definitive surgery in that arm versus 25% in the chemotherapy arm. So all those benefits and outcomes are against a control group in which 1 in 4 did not have surgery, which has to be borne in mind. There were some higher rates of R0 resection, higher rates of lobectomy, and lower rates of more complex resections like pneumonectomy. So in March 2023, a technology appraisal was published from NICE. So this was a recommendation that neoadjuvant chemotherapy and immunotherapy is an option. So this isn't a guideline. It was published as an option in pathologically proven, so it has to be pathologically proven non-small cell lung cancer, stage 2 to 3, that have been proven to be negative for the common EGFR mutations and for ALK fusion. Resectable disease, medically operable, with good functional status and no prior immunotherapy. So what questions does that leave in then translating that into real-world practice? So we've heard already about how are we going to better understand who would benefit best from adjuvant therapy. And we're much earlier in this journey of neoadjuvant therapy, of who are the patients that truly benefit the most from this. How do things like smoking status and mutation driver status influence the decision-making? Does PD-L1 status influence decision-making? So in other recent NICE approvals for multimodality treatments in the curative setting, so PACIFIC, for example, and maintenance IO after concurrent chemoradiotherapy, that was approved with a PD-L1 greater than 1%. But neoadjuvant wasn't. So is PD-L1 still important in that treatment selection? How does that influence our decision-making? That trial did not compare neoadjuvant and adjuvant treatment, did not compare the two. So how do we marry those two things up and try and make a decision with the patient in front of us? What are the implications for the diagnostic pathway? And as this is becoming increasingly complex, how do we deliver that in a timely way with a good patient experience? These are all ongoing questions. So which patients benefit the most? These are the forest plots and subgroup analysis. So the trial's not powered to show these differences, but I think interesting findings. The stage 2 and 3 disease, the positive results seem to be driven by the patients that have stage 3 disease. And PD-L1 expression, so this has not informed the NICE approval, but looking at the very top group there of less than 1%, so PD-L1 negative, the benefits seem to be driven by PD-L1 expression, although that isn't covered in the NICE approval. That's smoking status, and I guess what I'm saying there is about driver mutation status, and the two are intimately linked. So a patient that develops lung cancer who has never smoked, the proportion of which have a single mutational driver is substantially different from those that have smoked, which tends to create multi-mutational cancers where immunotherapy seems to work best. So these are just two graphs that separate. On the left is single mutational drivers in those patients that have smoked, with a very large proportion of unknown and a large proportion of KRAS. Whereas in those that have never smoked, there's a high proportion of EGFR, very high proportion of additional single driver mutations, with only a very tiny fraction of unknown. And that does seem important. You could take from lots of different areas where those single mutational drivers do not appear to respond to immunotherapy. So this is recently published, Keynote 783. It's looking at EGFR positive advanced stage lung cancer that are progressing through TKI therapy. But it's comparing chemoimmunotherapy versus chemotherapy alone. And we've all seen the dramatic differences in an advanced stage disease when immunotherapy has been added to chemotherapy, but not in single mutational driver. There's no difference in outcomes. This was seen in Pacific as well in the subgroup analysis. So just looking at EGFR status, those with a positive EGFR mutation do not appear to have the same response to maintenance immunotherapy that those that are EGFR negative. And that was only accounting for one of those single mutational drivers. So wherever we seem to look at it, there seems to be the pattern of single mutational driver and a lack of response to immunotherapy, which has to start influencing our decision-making in these complex pathways. A lifelong non-smoking status is right up, early up front, can start to inform where we're heading and start to inform our practice. I just highlight the PD-L1 again. The very bottom graph is the less than 1%, not too dissimilar from in the neoadjuvant group, that PD-L1 seems to help define the response to immunotherapy. So does smoking status and that lifelong non-smoking status, driver mutational status, influence our decision-making? Well, if lung cancer in never smokers is very frequently driven by single mutational defects that do not appear to respond to immunotherapy, then surely that does need to influence our decision-making and push us away from a pathway of neoadjuvant treatment in those areas. And I've put in as well that I'm going to come on and talk about it a little bit more, but rapid testing for biomarkers is important for neoadjuvant. We've got to know quickly. So for EGFR, something like a COBAS test, a single PCR test, will give us quick answers, but it misses some of the EGFR mutations. And if that's so critical in somebody, particularly somebody who's never smoked, by going down that pathway, we may miss an important mutational status. And with all the work coming through with adjuvant treatment in single mutation driver lung cancer, so osimertinib is here, the ALK inhibitors will be here, the ALINA trial was discussed at the most recent ESMO, and this is all coming now. Personalized adjuvant treatment for mutational driven lung cancer. And to get that in-depth pathological and staging data that is so critical in informing those decisions has to be an upfront surgical approach. There seems to be numerous arguments why in that subset of patients, and hopefully early on in the pathway, we can start to understand how we might make those personalized decisions. This is just some data about that COBAS testing, just one paper that compared COBAS and extensive NGS testing. It missed about 11% of EGFR mutations, and that's particularly the exon 20 mutations. So if we're doing rapid testing, that can be very good if you're not expecting to find an EGFR test, but it comes at the cost that it may miss some. So does PD-L1 status influence our decision-making? There isn't a trial to tell us that. Or does neoadjuvant, how does it compare to adjuvant? There isn't a trial to tell us that. PD-L1 does seem to be predictive. So if a patient was in front of you with a PD-L1 of 0% at stage 2, and seeing those two plots that we saw earlier, or node negative stage 2, is that different, where it's shown no evidence of metastatic behavior? Does that influence our decision making? It helps define adjuvant options. A PD-L1 of greater than 50% means somebody is eligible for adjuvant immunotherapy, assuming an R0 resection and they've had one cycle of chemo at least and adequate fitness. If it's a very borderline discussion, PD-L1 helps inform eligibility for concurrent chemoradiotherapy. Over 1% is eligible for maintenance development. In all these areas, it adds additional information, which begs the question, can you make a decision and have a fully informed discussion with a patient without that level? It feels like a critical piece of information to inform that personalized discussion. This is the Empower study that has led to the approval of immunotherapy in the adjuvant setting for a PD-L1 of over 50%. So both the Pacific data were stratified by PD-L1, by NICE, neither of which were primary outcomes. But in neoadjuvant, it's a blanket approval without a PD-L1 status. So for us, translating that into clinical practice, as I say, surely that becomes an important factor that helps an individual decision. So trying to think pragmatically about, we don't have direct comparative data. So are there advantages of one approach? Are there disadvantages of one approach? How would you try and list those or think about that in a conversation with a patient? So neoadjuvant appears slightly more resource efficient, 3 cycles of systemic therapy versus 4 or 1 year of immunotherapy in the adjuvant setting. There is evidence that a neoadjuvant approach has a higher completion rate with all elements of multimodality than adjuvant. So some of the randomized controlled trials, the actual outcomes are no different, but the proportion completing both aspects are higher with a neoadjuvant approach than with adjuvant. Higher rates of R0 resection from the 816 trial. They claim shorter duration of surgery, but then in the disadvantages I've put, which my colleagues have been educating me all about, is the increased potential complexities of operations after neoadjuvant. Longer time for prehabilitation, the pathological complete response rate. We don't know completely that is a true predictor of overall survival, though the data is building around it. And there are those that really quite vehemently believe about giving immunotherapy with a tumor in situ and developing immune memory. But 15 to 20% may not receive surgery. There is a delay to surgery for potential stage migration. Biomarker testing is creating complexities and delays in the pathway. It relies on clinical staging, which is not as accurate by any stretch as pathological staging. The overall survival data is still maturing, and this is a new pathway, very different to what we're used to delivering. So that's different from on the adjuvant side of where we've got known survival benefits. We've got accurate pathological staging with no debate over the eligible population. We're used to it, and it's a common, well-established current practice. But it is more resource intensive. There may be less uptake of the systemic element of it. So none of this is randomized control trial data, but just, I hope, represents the complexity of you, a patient who has those different treatment options, of trying to understand what might be right for that individual. That feels like a difficult conversation to explain, let alone be the patient trying to understand those things and be guided by us. So what implications are there for the diagnostic pathway? Genomic testing is a big one. This is some audit data from our region. that looks from the time of tissue acquisition, so that's generally after multiple staging scans, but just from tissue acquisition to final genomic results, so a median of 27 days with an interquartile range of 17 to 35, and we've got 49 days to deliver an optimal pathway. So we have to be thinking about that. So in Greater Manchester, one of the approaches we've had around is adjusting our reflex testing protocol to have a neoadjuvant pathway to try and facilitate urgent testing. That relies on very good communication between whoever's doing the diagnostic test, a physician, a radiologist, and the pathology team to explain that this person might be suitable for neoadjuvant treatment, at which point they will do rapid PD-L1 and ALK and a single gene EGFR COBAS test with a much quicker turnaround. They will, in our region, have agreed to double test, so they'll run the NGS as well, but we'll get the EGFR quicker to be able to make those decisions. And someone that's never smoked, that pathway just doesn't support what the information we need for those patients. So how do we deliver all this? How do we deliver that complexity? I'll talk about the approach we've taken in Greater Manchester, which may not be the way that suits everywhere. These are local solutions to local problems. We've brought together a clinic that's not just multidisciplinary, so a surgical team, anaesthetic team, medical and clinical oncology team, but also those that can hopefully optimize patients who are either having complex complex multimodality treatment or who have significant comorbidities, so oncogeriatrics, tobacco dependency, prehab. And one of the, I think, really good interventions from our surgical team has been to introduce a surgical friends meeting. You can ask Mr. Granato about the meaning behind the title. But this is the surgical team getting together the day before this clinic to review every referral, and this is the neoadjuvant referrals, so that there's some collective responsibility about defining resectability, so that surgeon in the clinic understands the views of his colleagues and has some support in that decision-making. So we first implemented this clinic to solve the pathway issue we had from early stage disease in high-risk patients that could have a resection or could have radiotherapy, because it was creating significant harm. That was a local issue, because people were bouncing between centres trying to make a decision. And the impact that clinic's had has been huge, particularly in the very long waits. It takes out those 100, 150, 200-day waits of really complex pathways. And we've got data from the first 6 months and now for the year after that clinic's been instigated. It's about a 5-day turnaround from a referral to a decision because of this clinic. And it seemed the obvious place to then cite the multimodality work and the neoadjuvant referrals where you could meet every person that has every potential treatment option. What I think really, what has really helped our outcomes is embedding that optimization. So because of the clinic, the uptake of prehab is up by 13%. The uptake of frailty interventions has gone from 4 to 41%. Tobacco dependency, so somebody leaving that clinic with their treatment and their support, it's gone from 15% to 90%. Same for malnutrition and for alcohol dependency. All those things that can then lead to the post-operative problems, the uptake of is significant, which I think is reflected in the outcomes. It is a resource-heavy intervention, but it is saving hospital appointments. So an average of 2.4 face-to-face hospital appointments has become 1. Our length of stay in what are high-risk patients has come down from 9 to 7. And the 12-month mortality, pre- and post-implementation, this is everybody, regardless of what treatment you have, from 12.8% to 3.5%, which I'm sure is driven by quicker decision-making and by the uptake of optimization. So it feels like the right place to deliver patient-centered decision-making for multimodality treatment. And we had to really fight for this. The NICE approval was in March, and we started doing this in November, and a lot of that was around arguments around funding. That NICE approval ensures the medications are funded, but this is a complete pathway transformation of meeting a surgeon and an oncologist up front that needed some extra resource. We had to really fight for that to happen and not to just let it happen with disparate hospital appointments. And I think our data, even early data, helps support that. So 23 referrals since we started the Neoadjuvant service in November. But actually, through that clinic, 8 of them did proceed on to Neoadjuvant, with nearly enough going for upfront surgery and alternative non-surgical treatment regimes. And the reasons behind that are varied, about concerns over treatment-related toxicity. Someone on paper may feel very good for neoadjuvant treatment, but there are things that come out. Peripheral vascular disease seems to be particularly one of them. Doesn't seem to get the emphasis required on local MDT discussion. Someone comes to clinic with quite marked peripheral vascular, which our oncologists are very hesitant about with chemotherapy and immunotherapy. And they may go on to have upfront surgery. Patient preference, EGFR mutations, all reasons why, with all of this complexity in decision-making, we might have these referrals for neoadjuvant, but the reality is it needs a complex MDT to try and make those decisions. What, for me, is a good marker is that our median time from referral to decision to treat is 7 days. It's slightly longer than the earlier stage ones, but we put processes in place. So a lot of patients do have a PD-L1 when they're seen in that clinic, because it feels to be such an important piece of the jigsaw to help make that decision. It's not quite as high with EGFR, but we've got a lot of those results, and hopefully, and I'm sure that's what supports why we make a decision on 9 out of 10 on the day. So, multimodality treatment is becoming increasingly complex. It's going to become more and more complex as we learn about neoadjuvant and adjuvant treatments, and as this develops. And that integration of more effective systemic agents, it's a paradigm shift. But we've got so many unanswered questions about patient selection and about staging, about biomarker testing, about selection, about the best way to deliver these services. And the one-stop model is just one of those. But that clinical decision-making, this seems to have been a theme throughout today's talks, that decision-making has to be supported by shared decision-making from all disciplines on a case-by-case basis that take all of those different factors into account that aren't answered within randomized controlled trials. So thank you very much.